Thanks. I've been asked to talk to you today about stem cell transplants and how we've used them to treat MS and where the field is likely going. So for an overview, first I'd like to give you a little bit of background and try to convince you that we really don't know what we're doing. We don't know what causes MS. If we did, I wouldn't be up here. I would be on a plane for Stockholm to get my Nobel Prize. Then I want to talk about some of the immunology of what we do know about transplants, and then some of the treatments, including other immunosuppressive treatments, and then the two types of bone marrow transplants that we do, and then finally wrap it up with a few words about the upcoming study. This is a slide that I borrowed, so to say, about midnight from Dr. Buster Alvord's lab. And you probably can't see it well, but it starts in 1944 and it ends in 1984, which is when I snuck into the lab and borrowed it. Since then, the keys to the lab have been changed, so I couldn't get the most updated slide. But every time this line goes up, they thought that MS was an autoimmune disease, and every time it goes down, they thought it was related to a virus infection. And since 1984, it's gone up and down many, many more times. And as the papers come out at an increasing rate on this disease, sometimes I think this line bounces up and down, month to month or even week to week sometimes. So a few comments about why we think MS might be autoimmune. And basically this whole conference has been talking about this, so I don't have to dwell on it too much. But there are a lot of immunocytes, T cells, B cells, that are in these MS plaques. We find them in the cerebral spinal fluid. We can also find subtle changes in these in the peripheral blood, and some of these changes precede attacks that occur. There's experimental allergic encephalomyelitis, which is the animal model, which is entirely an immune-mediated condition. There's linkage to certain HLA types. Those are those transplant antigens that they have to match to do organ transplants. And certain linkages to HLA have been found with a number of diseases we think are autoimmune disease, and it's no different with MS. It's especially HLA-DR2. And finally, we've had some success with immune-directed therapies, with the interferons and some of the other immunosuppressive therapies, especially the recently introduced natalizumab, which is probably one of the most pure immune-mediated plays, if you would, in our drugs that we use to treat this disease. Then there's the viral theory of MS. And this is based on a lot of geographical data. There's a north-south gradient to this disease that goes around the world. There's also a corresponding gradient in the southern hemisphere. There are migration studies that show that your risk of getting MS is determined before the age of 15 and is determined by where you grew up. So looking out at the audience, it's too late for most of you to move at this point. There are also some clusters of MS, with the most famous being the Faroe Islands, where there were no cases ever of MS before the British invaded those islands. And then as soon as the British invaded during World War II, within 3 years, there was a huge epidemic in, I believe, around 23 cases, which is big for those small islands. There are several other clusters as well, including Iceland and one even in Mossy Rock, Washington. There are other viral demyelinating diseases, and there are just tons of viruses that attack oligodendrocytes. One disturbing thing is that if you look at MRI scans, you can have a lesion getting worse on one side, and on the other part of the MRI you can have a lesion improving. So if this is an autoimmune disease where the immune system's just messed up, how can it be messed up on one part of the brain and getting better on the other part of the brain at the same time? There must be some local factor in the brain that's causing this immune attack, and some people think that might be a virus. There's the same linkage to HLA here, and we often forget that HLA determines not only our ability to react to our own antigens and autoimmunity, but also the ability to react to foreign antigens like viruses and things. After a lengthy search, we have still not been able to identify the antigen target that this autoimmune process is allegedly attacking. And then most of our immune-mediated treatments have failed. The few that we have are the unusual ones that succeeded, and most of them have not worked. And then finally, there are some pathology changes that suggest that at least not all types of MS are compatible with autoimmunity. And that's some of Claudia Lucanetti's work that was presented a couple of days ago. There's another recent line of evidence that was published a couple of years ago by Jack Prenius's group out of Australia, and this was an unusual case report. And before you get overly disturbed by this case, keep in mind that this case is a little bit over 30 years ago, so I think most people would have survived this nowadays. But this was a case of a teenager that got MS and over a 9-month period had 4 attacks, and the 4th attack was fatal. And it was fatal within 17 hours of the onset because it was a huge brainstem lesion. And so they've just now, 30 years later, gone back and done the pathology on this, and they've found that there's basically little to no inflammation in this acute lesion. But in contrast, really all of the oligodendrocytes in this lesion were dying through a process called apoptosis. Well, apoptosis is like a suicide pill that all of our cells are programmed to do, and we use it normally through our lives. Like in embryogenesis, we develop perhaps 10 times as many brain cells as we're supposed to have, and then we kill off 90% of them, leaving hopefully us with the best 10%, though clearly there are examples where that didn't occur. And we'll leave politics out of it. We also use this process to kill off cells that have been infected by viruses or cells that have tumor potential. So it's fairly widespread pathway that we have in use. This is a picture of this, and on your right, this panel, these are normal oligodendrocytes, and on the left you can see the nucleus of these are small and black, and that's because they are being destroyed internally by apoptosis. So that's all I'm going to talk about our ignorance about the cause of MS, and now I'll talk more about attempts at treating this with immunosuppression. So what happens when we give people a bone marrow transplant and replace their immune system? Well, it turns out that short term we basically kill off all the cells, but a number of them very quickly replenish. So fortunately, the red cells and some of the white blood cells, especially the ones that fight bacteria and platelets, they all recover in 2 to 3 weeks nowadays, which is a great improvement over the 3 to 4 months it took them to recover just with the techniques we were using just a few years ago. The lymphocyte counts generally recover within 3 months, but there are long-term changes in these lymphocytes that are not reflected in their overall numbers. There's a change in the CD8 and CD4 ratio, with the CD4s being decreased. There's preferential loss of the naive cells that are CD4. There is less effect on the memory cells for CD4s. There's a profound depletion of B cells that are IgG positive. These are the ones that react to new antigens. But the ones from the B cells that are left over, actually I said it backwards, these are the ones that react to old antigens. The ones that react to new antigens with IgM and IgD are affected much more. Natural killer cells bounce back within just a few days. And then the T cells that do make it through this process tend to be able to react to a much smaller group of antigens, And that's because when we develop T cells as infants, they go through the thymus to be trained on how to be proper T cells, and adults basically don't have thymuses because they atrophy. And so most of these cells are trained in the bone marrow, and they don't go through thymus training school, if you would. So again, the natural killer cells are normal almost immediately. The total B cell counts recover within 1 to 3 months, and then they often overshoot and get even higher numbers than they had before. The CD8 cells recover in 3 to 6 months, again often with an overshoot, but the CD4s have a prolonged loss. And I have a bunch of slides to show this stuff. Here's the natural killer cells, and you can see that almost immediately they're back up to normal levels. These are the B cells, and it's taken almost a year for them to get back up to normal levels for some of these. And for the IgD, these are the memory cells, it can take a very long time for them to come back. These are the CD4 cells, and again, you can see it can take even a few years for them to get back up and running. Although, and then the regulatory suppressors, it takes quite some time for those. And these are the CD8 cells, and you can see also it can take years for them to totally recover. So you can see that even though we say that we're given a bone marrow transplant, we're actually not killing off the entire immune system, and there's different parts of the immune system that are recovering faster than other parts of the immune system. So how a patient, how their immune system reconstitutes depends on the balance of all of those factors. So one slide on other immunosuppressive treatments. We've had some success with these, and this is the short list of drugs that are used to treat MS from an immune suppressive standpoint. This doesn't take the ones that are immune modulating. But the only one on this list that is widely accepted is mitoxantrone, which has good studies to back it up. The others, for the most part, have not had studies of adequate design to prove whether they work one way or another, but at least there's some evidence that they may be successful. So with bone marrow transplants, the idea was to just take this one step further, and if a little bit of immune suppression is helpful, maybe a lot will be even more helpful. So when you do a bone marrow transplant on people, there's a number of stages that you go through. One is that really most of these studies, or all of them really, are where we take the patient's own bone marrow and give it back to them. This is much safer than taking someone else's bone marrow and giving it to the patient. So first you have to mobilize their stem cells so that you can collect them. And there's a couple of ways to do this, either with cyclophosphamide or with GCSF. Problem with GCSF is it can cause MS attacks, so we have to give steroids to prevent those attacks while we're giving the GCSF. Then you have the condition, which is the polite way that the oncologist, that's the polite word that oncologists use of killing off the bone marrow. And there's at least 4 different ways that have been used to do that. And then you can either deplete the thymocyte cells or not, so that's with ATG. And then you give the transplant back, and then you have to, as the transplant starts to take and grow, there's this storm of cytokines that are often out of balance, and you can get MS attacks during that time as well. So you have to once again give steroids to ward that off. So there are several studies that have been done with this, and I'll just run through them quickly. This is the study from Northwestern in Chicago. It has 21 cases. The mean EDSS was 6.3, so 6 means you need a cane, 6.5 means that you need 2 canes. And they found that patients that had an EDSS of less than 6 tended to remain fairly stable 6 were worse by a half point, but you can't believe a half point on this scale because the same doctor examining patients twice in a row, a 1 point difference is what that doctor can detect, and the half point is noise in the outcome measure. If they were more worse than an EDSS of 6, then 8 of them had gotten worse by 1 point. This is our study. It was a collaborative study, but the home center was in Seattle. We have 26 cases. The mean EDSS was 7. And this has the 2-year data where 6 were worse by a point, so 6 out of 26. We now have 5-year data on these people that's not fully analyzed, but basically the results look very similar to this. The City of Hope in Los Angeles has 5 patients, mean EDSS of 6.5, and one of their patients got worse from the MS standpoint. One of them died from a fungus infection, unfortunately. This is the series from Greece, which at this point had 24 patients. Again, the EDSS was 6, and they have 3 years of follow-up with 5 of the 23 progressing by 1 point. This is the Spanish group, 14 patients, EDSS of 6, and only 2 out of the 14 had gotten worse at 3 years. And then this is the Italian group, 19 patients, EDSS of 6.5, and 3 of those had gotten worse at 3 years. I think there's one more. Yeah, this is the European Bone Marrow Transplant Database, where they have all the patients that get transplants in these databases, and they just pulled all the MS cases out, which was 85. So this includes the numbers from all the previous European studies that I showed you. And again, the mean EDSS was 6.5, and there were 74% that were free of progression at 3 years. So somewhere between 75 and 80% of patients that get these transplants appear to be stable at 3 years. And this is fairly impressive when you think that it is the worst of the worst cases that are enrolled in these studies. So none of these studies would take patients unless they had failed conventional therapy and had failed not only in a minor way, but a fairly major way. So most of them had to have declined at least a full point on the EDSS in the previous 12 months. And now 75–80% of them are stable for 3 years. There's some suggestion that maybe it's more beneficial in earlier disease, but as you could see from those mean EDSSs, there weren't very many cases in early disease that had been studied, and all of these people were 6.5s, or the mean was 6.5. So very few early cases to judge it by. There's some suggestion that relapsing remitting might be served better by this, but again, most of the patients were secondary progressive. But there is a downside in that there were 7% deaths on this treatment. We think that we can improve on this because we learned a lot on how to do these transplants in MS patients. So we think that we can improve on this 7%, but that's what we have coming into it today. So this brings up an interesting dichotomy. So on the one hand, it looks like this was probably a successful treatment that slowed down this disease a fair amount, but the other side of the question is, why didn't it cure the disease, and why is there 20 to 25% that are still having some disease activity? And we don't know the answer to that. One is that we may not be killing off the immune system, and as you can see from the previous part of my talk, we're not killing off the immune system. We're just changing it. It could be that if we suppress it more, that we could be successful. It may be that we're transplanting patients too late, and that once a certain amount of damage has been done, that it's irreversible, and that these cells just don't have the support systems that they need, and that they're destined to die no matter what we do to the immune system. And then, of course, the final thing is that we may be barking up the wrong tree entirely. It may not even be an autoimmune disease. So this is a slide to show you that perhaps we're not being aggressive enough, if you could believe that with a bone marrow transplant. This is those spinal fluid analysis for oligoclonal bands, and the column on your left is before transplant, the one on the right is after transplant, and these are in the same patient. And you can see these faint lines across here. These are lines of immunoglobulin. Each one is made by a clone of B cells that's in the central nervous system. And you can see that these lines are exactly the same before and after transplant. So we've gone back. We have 19 patients that we have before and after spinal fluid. And out of the 19, 17 of them had bands before, 17 had it after, and it's the exact same bands. The two other ones did not have bands to start with, and one of them didn't have bands afterward, and the other one developed bands. So we're not killing off the memory B cells with this treatment. There was a conference about a year and a half ago that I went to, and I wish I could remember which immunologist said it so that I could turn the heat toward him instead of me, but he said that the memory B cells are the cockroaches of the immune system because we can't kill them with anything. This is a slide of some of Hans Lassmann's work, and it shows a slice of cortex, and on the far left is the classic slide of myelin stain, and you can see the dark blue is the myelin, and then there's this chunk up here that's missing, and that's a classic MS lesion. He's gone on to do these special stains that are much better at picking up myelin changes in the cortex, and on the cartoon on the far right, you can see the orange. That's the area of the cortex that has been demyelinated that you can't see with these standard stains. He's found that there are a lot of MS patients that have these lesions, and especially if you get more into the progressive, the secondary and primary progressive forms of the disease, it becomes more prevalent. And one postulation is that this causes some of the progressive characteristics of the disease. One aspect of these lesions is that the inflammation is very low level, though it is ongoing, so it does not cause breakdown of the blood-brain barrier. And as such, that means that we cannot get treatment into it because most of our drugs don't cross into the brain unless the blood-brain barrier is disrupted. So it may be that this might be a reason why our immune suppressive treatments are not working as well as we would like, because we're able to suppress the immune system except in this area where we can't get to. So that's another reason why perhaps more aggressive treatment than even bone marrow transplant may be needed. So this brings us to allogeneic transplants. This is where you take someone else's bone marrow and give it to you. We don't do this in MS because it has about a 30% mortality rate, which is just completely unacceptable. But we do it for patients that have cancer that they would have 100% mortality if we didn't transplant them. So we have gone back, the group at Fred Hutch and ourselves in Seattle, and we've looked through the registries, and there are a number of people across the world that were unfortunate enough to have cancer and MS. So we looked at the ones that had transplants, and we've actually brought a good number of them die from the cancer itself. So we've looked at the ones that survived all the cancer and brought the survivors back to Seattle. There's 8 of them in North America, and I believe there's 6 in Europe. And we tried to convince them that they needed to do home visits in Europe, but that didn't work. So we have colleagues in Europe that will be examining these patients for us and giving us follow-up. But anyway, of the 8 patients, they really are all stable, and many of these are getting out to 5-6 years after their transplants. And we don't have prior spinal fluid on them because they were more concerned about cancer and stuff, but we did spinal taps on them now, and out of the 8, only 2 of them have oligoclonal bands, which is odd because 90% of MS patients should have oligoclonal bands. So this is much lower than you would expect and suggests that maybe this allogeneic transplant is capable of killing those memory B cells that we didn't get otherwise. Of the 2 remaining ones, One of those patients is our patient in Seattle, and her oligoclonal bands that still persisted were persisting at 6 months, but they were already fading. They're much fainter than the prior, the pre-transplant study. And we suspect hers are going to disappear. She just got her 5-year spinal tap last week, and I don't have the results yet. So what we believe happens with allogeneic transplants is that when you transplant someone else's bone marrow in there, the new bone marrow and then the patient's original old bone marrow fight it out, and you get this graft versus host disease. And since the patient's own bone marrow has been beaten up with all this chemotherapy and stuff, the transplant wins out, but it takes it several months, perhaps 9 to 12 months to win out. And this may be one of the only ways that we can truly eliminate the patient's innate immune system and replace it with another one. So finally, just a few words on the upcoming study. There's a study that's starting now that's going to be done at 3 centers across the country. And we're going to do another round of autologous transplants, which is giving patients their own bone marrow back, to try to learn more about it. There's going to be 30 patients, and one major change between this and previous studies is that we're going to move earlier to try to get away from that question about whether we're just waiting too long and waiting until the horse is out of the barn to treat these patients. So we're moving an EDSS of 3 to 5.5. And then, again, we want patients that have very active disease, because the other part of the question that some people have brought up is that if you wait too long, maybe the inflammatory part of the disease is over and no immune-directed treatment will work at that point. So we want them still to be having attacks so that we know that they're immunologically active. So they can either have 2 attacks in the last 12 months or 1 attack and then some MRI evidence that their disease is active. And we're going to use this particular beam ATG way of doing the transplant itself. And then we're going to do 5 years of follow-up looking at both how they do clinically, but also some of these fancy MRI techniques that you've heard about with magnetization transfer, MR spectroscopy. And then we're doing a lot of studies through the NIH of the cells, the immune cells, to see what cells are coming back so that we can hopefully get a better understanding of if we are not 100% successful, of why we may not be successful. So in conclusion, we think that this high-dose immune suppressive treatment does slow down MS, but it's not 100%. We've been able to really reduce the morbidity and mortality of the procedure. It's possible that allogeneic transplants may be even more successful, but right now they're not practical for your usual MS case that doesn't have cancer or something like that. And we think that this further study that we have is going to help us answer the question of whether this disease is or is not autoimmune, whether we should be treating it earlier than we are, and what degree the immune suppression has to be done in order to get success. So thanks for your attention.